Okay, so hello and welcome to episode 4 in the Lister webinar series. My name's Oscar Swift and I'm joined by Alex Riding. We're two of the renal registrars here at the Lister. It's the 15th of April at about 11 a.m. and we're going to spend the next 30 to 40 minutes just discussing about some renal issues with COVID-19. And we'd also like to thank Andy Findlay, who's one of the consultant nephrologists here and the AKI lead at the Trust, for helping us with this presentation. So what are we going to talk about today? So we're going to talk, in summary, just talk a bit about acute kidney injury and the relevance and importance of managing acute kidney injury well in patients with COVID-19. We're going to talk about fluid management, which relates to acute kidney injury, and what we should be trying to achieve with fluid management. We're going to talk a bit about ACE inhibitors and angiotensin receptor blockers and what we should be doing with these medications in patients when they're coming in. We're also going to talk about renal replacement therapy, mainly looking at it from a critical care aspect and what things we should be doing, and what strategies we should be trying to look at to sort of maximize our renal replacement therapy capacity in ITU. We'll also talk a bit about some specifics regarding dialysis and chronic kidney disease patients with coronavirus and some focus on that. And then lastly, we'll also touch on patients that are on maintenance immunosuppression, either because they've had a transplant or because they've got another autoimmune condition, and what we should be doing about that. So I think without further ado, I'm going to hand over to Alex, who's going to just go through a bit on acute kidney injury to start with.
Thanks, Oscar. Morning all. So I think a bit of background first. So AKI estimates, it's been difficult to quantify because people have used different classifications for rating AKI. And of course, the data has all come out of single centres, specifically a lot from Wuhan. And owing to variable testing rates and recording of AKI, that leads to wide estimates of the rate of AKI, so anything from 0.5% up to 23%. And typically, these hospitals are seeing AKI developing at a median of about 7 to 15 days into the admission of a patient. And why is this important? Well, we know from data that we already have patients who are unwell and who go on to die, and from being typically critically ill, that mortality rises with each AKI stage. So you can see there, I've given you the hazard ratios for the stage 1 AKI. Your risk of mortality rises to 1.7 and then up to 6.9 in a stage 3 AKI. So going back to COVID patients, and again looking at a lot of this data that came out of Wuhan, for those that did die of COVID infection, AKI was reported in 11 to 32% of those patients. So what's causing AKI? I mean, typically, I think for the majority of patients, this is going to be a pre-renal injury. This is going to be acute tubular necrosis because of dehydration in critically unwell patients. So they're suffering, as I say, this pre-renal injury. And actually, interestingly, a couple of days ago, there was a paper reporting histology findings from patients who had died of COVID infection and looking at their renal histology. And the majority of patients had an acute tubular injury. So congruous with this idea that actually there's a lot of ATN in COVID infection. Interestingly though, when they looked at these samples with electron microscopy, and we couldn't resist showing you some renal pathology, you can see on the electron micrographs at the bottom of the screen, those red arrows are pointing towards virions, so virus particles within renal tubular epithelial cells. And that seems to be more specifically the proximal renal tubular epithelium. And some RNA sequencing data has shown that ACE2, which is the enzyme associated with viral entry to cells, is more highly expressed in the proximal renal tubular epithelium. And that does seem to be, therefore, somewhere where the virus might more specifically affect the renal epithelium. And you guys may have noticed on the blood work of some of your patients low phosphate and potassium levels. And while there might be many reasons for that, one of those possible reasons could be destruction of proximal renal tubular epithelial cells, where those electrolytes are normally reabsorbed. It also represents a possible point where the virus might actually be causing direct renal injury. So if we think clinically where we might be seeing an intrinsic renal injury, that's why it's so important when you have a patient with AKI to get a urine dip and look for protein and evidence of hematuria on that urine dip. And looking back again at data, particularly from Wuhan, proteinuria and hematuria was present in about 27 to 67% of patients with an AKI presenting to hospital. So does that represent intrinsic renal damage? Does that represent invasion of cells by the virus? Does it represent other underlying renal pathology? Was it perhaps normal for the patient? Are we just picking up these urine dips in patients who've got an IgA nephropathy or an FSGS anyway, and they're happening to present to hospital and we're doing a urine dip? In short, we don't know the answer to that question. And that's why it's really important not to forget to send an acute renal screen in this sort of scenario and make sure that you're screening for all of those renal causes of AKI in patients. So how are we going to manage these patients? How are we going to prevent AKI and respond to AKI and COVID infection? Well, given what I've just said, that most renal injury is occurring because of pre-renal failure and dehydration, this is largely going to be based on good fluid management. So I think do all of the things that you would normally do. Stop nephrotoxics, stop things that are going to affect kidney function, and stop diuretics. Don't dehydrate your patient more. And as we've already mentioned, this acute renal screen is really important. Consider other causes. So get that urine dip, look for blood and protein, and send your acute screen. And we've added to your sort of routine screen, your autoantibodies, complements, and myeloma screen. We've added a CK as well, because there were some early reports of rhabdomyolysis, though we're not seeing those high CK levels that were reported from some of those Wuhan papers. And don't forget, of course, obstructive causes of AKI. If you've got a patient with AKI, get that renal tract ultrasound or CT-KUB. Radiology are still doing these scans for us. It's really important that we think broadly and rule out any other causes of AKI in this scenario. So on to fluid management. I think essentially, again, treat your patient in the way that you ordinarily would. So it's really important if you've got a shocked patient or somebody who's very dehydrated that you fluid resuscitate them. So do what you'd normally do. Boluses of fluid, 250 to 500 ml. Caution if you've got a patient who's frail, elderly, or heart failure, and reassess and repeat that as necessary to get them euvolemic. And I guess it's worth mentioning at this point that reassessment is a slight sticking point in that you want to limit your exposure time to patients who might have COVID. But there are, of course, other parameters that you can use, such as urine output monitoring, blood pressure and heart rate measurements. So make sure you use all of those. Look at the JVP, look for peripheral edema as part of your reassessment and fluid status, which hopefully should minimize any direct contact with the patient. It goes without saying, of course, that a lot of patients with COVID infection have bibasal crepitations or bilateral crepitations, so that may be a less useful feature anyway in this context. Once you perform fluid resuscitation as necessary, it's then really important to keep these patients hydrated. It's going to be that dehydration that causes kidney injury. In the context of, I think you probably join me in recognizing that we're seeing very high persistent temperatures in a lot of our COVID patients, temperatures of 39, 40 degrees, sometimes persistently for days. So let's think about how much a patient might need in terms of their kind of maintenance fluid. If you've got a nil by mouth surgical patient, then you're kind of thinking along the lines of 25 to 30 mils of fluid per kilo per day. Now, if your patient's nil by mouth, then you've got to give all of that IV. Our patients typically aren't. So you've got to think about how much your patient might be taking orally, and then thinking about their access to water, particularly if they're constantly wearing an oxygen mask, and thinking therefore about how much you have to supplement IV. Add on to that any fluid that you need to replace for these high persistent temperatures. Now, we struggled to find exact guidance on this and came across a figure of 250 mils per extra degree of temperature. Now, I think that's fine if you've got a patient who is spiking the odd occasional temperature. But for our patients with very persistently high temperatures, we are suspecting that 250 mils per degree is simply just not going to be enough. And there is no replacement for going back and reassessing your patient and giving extra fluid if they're dry. And we would anticipate that 250 per degree is going to be a minimum. extra fluid per day for your patient. You may find that you need to give far more than that. You need to be making that fluid assessment at least daily, and obviously much more than that if your patient is unwell. And I'll talk a little bit more about ARDS on the next slide. So as I've said, be really careful about patients who've got limited access to water. You may find the balance of fluid that you're giving does need to be more intravenous than oral. And I think reassessment and keeping an eye on patients' fluid status is difficult in this scenario. So do consider early catheterization and urine output monitoring as a really good way of keeping a close eye on your patient and managing their hydration status. So as I said, I was just going to mention a little bit about ARDS. So I think on the whole, we need to be maintaining good hydration in our patients, but there is a scenario in which we may want to limit fluid intake. And I think quite understandably, a lot of confusion has arisen over this instruction to keep patients dry to protect their chest in the case of ARDS, but hydrated in the case of prolonged pyrexia and protecting renal function. And after having a chat to some of the respiratory guys about this, it seems that in patients who are deteriorating from a respiratory perspective and requiring ventilation, those patients seem to be falling into two categories: those with this atypical pneumonitis and those then with this ARDS picture. And it is in that subset of patients that we want to be perhaps limiting fluid intake. And if you look at guidance for management of ARDS and fluid, and the guidance is actually to aim for euvolemia or slightly drier. It's not to stop all fluids and run your patient completely dry. That is not correct. We all need fluid, albeit at slightly reduced levels if you are worried about ARDS. So if you've got a patient on the ward who is deteriorating, their oxygen saturations are falling despite increasing their oxygen rate, their work of breathing is increasing, then obviously you need to be checking their treatment escalation plan, escalating that early to ITU and critical care. Because then they will get the ventilation that they require, and of course they'll be able to monitor their fluid status much more closely in that scenario. So it's very important that you do that, and while you're waiting for that review, it's entirely reasonable then to start reducing the rate of fluid replacement while keeping a careful eye on urine output, blood pressure and heart rate. Of course, it is worth mentioning that if you've checked that treatment escalation plan and your patient isn't escalation to ITU and therefore ward-based care, then I think the same rules still apply. So begin to reduce the fluid rate, but keep a very careful eye on their hydration status. You don't want to overly dehydrate these patients. And that's where urine output monitoring might be really, really useful in this scenario. Of course, if you're reaching the point where your patient has respiratory compromise and you're beginning to notice peripheral edema, then that obviously represents a pretty sinister turn for your patient. And I think we would recommend a very early senior review in that scenario. And it may be that is a point at which the situation is not recoverable, and it's worth thinking early about whether the best management for that patient is taking a more palliative than active approach. We also wanted to mention a specific scenario of fluid management for those with an AKI when they already come into hospital. So those who might have an acute on chronic renal injury, or perhaps a stage 2 to 3 AKI. You've probably already noticed that the AKI team who used to come around and see stage 1 and 2 AKIs have not been able to do that because that team have been redeployed to other places in the hospital. So you will have to manage this situation initially on the wards. And I think, again, it's really the same advice that we've been reiterating in the earlier slides, and that is fluid resuscitate your patient, aim for euvolemia, and try and recover their hydration status, and use boluses if you're unsure, and reassess often. If you catheterize and get an hourly urine output, that's going to give you a really good idea of how your patient is responding to your fluid management and if they are able to produce urine, because what you want to avoid is overloading your patient while also making sure that they are adequately hydrated for their kidney function. And I think if you've got this scenario where your patient isn't improving with your initial fluid management, or they're coming in with a stage 3 AKI, then please call renal early for some advice.
Okay, thanks, Alex. Just going to talk very briefly just about ACE inhibitors and angiotensin receptor blockers and what we should be doing with these medications in patients coming into the hospital. So we know that hypertension is a risk factor for adverse outcomes with COVID-19. data published last week out of Lombardy in Italy actually showed that out of the 1,591 patients that were in their intensive care units in that area of Italy, basically half of them had a history of documented hypertension, which was the most common comorbidity of all the patients in the intensive care unit. Obviously, it is a very common comorbidity anyway in the general population. And there's been a lot of theories about whether actually using ACE inhibitors and angiotensin receptor blockers will cause extra harm or may actually be beneficial in COVID-19 infection. As Alex had mentioned earlier, the virus gains entry into cells of the body via the ACE2 enzyme. And there is some thought that actually ACE inhibitors and angiotensin receptor blockers actually potentiate ACE2 along with things like NSAIDs. And so that may actually be a risk factor for high viral load and high risk of sort of severe disease. However, other people actually think that inhibition of the renin-angiotensin aldosterone system may actually be protective against COVID, but it's really not clear. And actually, there's a clinical trial running at the moment looking at losartan in patients with coronavirus. So I think, given that it's not clear, we're not telling patients to routinely stop their ACE inhibitor or angiotensin receptor blocker, especially if they're well and in the community, because we know certainly in diseases like heart failure with a reduced ejection fraction or proteinuric CKD, that can lead to decompensation of these conditions and actual hospitalization as a direct result of this decompensation. So the sort of message is, if patients are well, they should continue on their ACE inhibitors as they normally are doing. However, in terms of if you're faced with a patient that's been hospitalized, who you're seeing in A&E or in A&E who's on an ACE inhibitor or an ARB, this sort of schematic is very helpful in just determining what you should do with their medications. So essentially, if there's evidence of hypotension or hyperkalemia or an acute kidney injury, then I would say I would make sure that the ACE inhibitor is stopped, and then make a considered judgment if you think that they've got decompensated heart failure about whether you continue that or not. But I think, in the majority of these people, if they're hypotensive, hyperkalemic, and an acute kidney injury, I would stop the ACE inhibitor. But I think the key thing that we all need to remember to do is, as we should do in sort of routine life, make sure we're documenting this on the TTO with a sort of clear follow-up plan for the GP in terms of how to restart it and what parameters they should be acting on to restart this if the patient has had an AKI or a high potassium, when the patient should be getting a repeat blood test and the follow-up for that, because I think it's leaving them off it long term that is where people can run into trouble. Okay. Just going to spend a bit of time now on acute kidney injury and renal replacement therapy in the context of COVID-19 infection. Because latest data that's coming out of ICNARC, which is a UK ITU database, is showing that actually kidney injury in critically unwell patients in intensive care is very, very common in the UK. And part of this may be as a result of patients being managed and kept dry on the ward. So what the data is showing is that of all patients in ITU, about 19% of them are requiring renal replacement therapy. And actually, if you're looking at ventilated patients, then the figure goes up to 26%. And because of the large number of ITU patients we've got at the moment, figures are sort of estimating around 1,500 people in ITU. This is a significant proportion and significant number overall of people that are needing renal replacement therapy. So this goes back to what Alex was saying, and actually prevention of avoidable AKI is a critical goal in management of these COVID patients. And really, if you're looking after these people on the ward, preventing them from getting in an acute kidney injury is a very, very important thing for you to be doing for these people. We also know that if the patients are hypovolemic, there is reduced lung perfusion, which can also affect their ability to oxygenate. So it's not just thinking about from the kidneys. Actually, being hypovolemic is not good for your lungs either. And as Alex had said earlier, actually, if we're aiming for a neutral balance with hyperpyrexia and other insensible losses, we could be in effect 2 to 3 litres negative over a 24-hour period. So I think it's really being very careful in your fluid balance assessment and really making sure that we are avoiding hypovolemia in this group of patients. There's been a bit of talk around sort of PEEP and how using high PEEP settings may actually lead to reduced cardiac output and acute kidney injury. And there's a bit of theory that actually using a slightly lower PEEP may actually help to prevent acute kidney injury. And then lastly, I think particularly initially when we were faced with this crisis, a lot of people were using diuretics in form of loop diuretics like frusemide to keep the chest dry essentially and give a forced diuresis. And actually the evidence now is that this is probably contributing to some of the renal injury that's being seen in intensive care and the consequent mortality with this. So we wouldn't be advocating a forced diuresis to sort of generate a hypovolemic state, because I think that actually might be making mortality worse. So just going to touch briefly on the different forms of renal replacement therapy, as we're having to now potentially become quite innovative in the types of treatment we are using in these patients. So this sort of schematic refers to dialysis. So dialysis is a treatment where you remove toxins from the blood via a process called diffusion, which is essentially the movement of molecules from an area of high concentration to an area of low concentration across a semi-permeable membrane. And so in dialysis, blood is passed through little fibers in a dialyzer, and around those fibers is something called the dialysate, which is a fluid that contains sort of homeostatic levels of sodium, a low amount of potassium, because obviously you're going to want to be removing that from the blood, a higher than homeostatic level of bicarbonate, so that you're correcting the acidosis that occurs with acute kidney injury, and other things such as calcium as well. So in dialysis, we're using this to remove toxins from the blood via diffusion. The other form of renal replacement therapy is filtration, which is the treatment that's most commonly used in an intensive care setting. And this uses, rather than using a process called diffusion, it uses a process called convection, where essentially pressure is applied to the membrane, and essentially molecules are removed from the circulation by a process called convection, which is where the pressure drives the molecules across the membrane to remove them from the circulation, as opposed to dialysis, which was a diffusion process. This process of filtration means that a large volume of fluid is also removed from the circulation and has to be reinfused back into the patient in the form of preformed bags, which are sort of 5-litre bags of an isotonic solution. So just comparing the sort of situations where we should be using these different forms of treatment. So at the top here, we've got IHD, which stands for intermittent hemodialysis, which you should think of as the standard outpatient dialysis treatment. Then we've got something called SLED, which is called sustained low efficiency dialysis, which in effect is essentially the same as intermittent hemodialysis, other than it takes place over a longer period of time and that the blood flow rates that we're using are slower than intermittent hemodialysis. And then the last type of treatment is something called continuous renal replacement therapy, which is often hemofiltration, which is a continuous treatment that is performed in ITU. So just comparing the sort of blood flows that we're using for these different treatments. So intermittent hemodialysis often uses a high blood flow because the treatment is relatively short and only occurs 3 times a week for most patients. Whereas in SLED, this is a daily treatment that's done for longer, so 6 to 12 hours. And actually, so therefore we can use a lower blood flow, which may help confer some improved hemodynamic stability compared to intermittent hemodialysis. And that's an important point to think about, as these patients when they're in the intensive care with coronavirus can have quite marked autonomic dysfunction with rapid fluctuations in blood pressure, and their sort of cardiovascular status can be very difficult to manage. So actually thinking about using something like SLED may be more helpful with that. Continuous renal replacement therapy, again, it's a very gentle treatment that is often performed continuously over a 24-hour period for a number of days at a time. The issue with this treatment is the number of filters and number of filter machines that are available in the ITU, which is why we're having to be a bit more thoughtful about this, which we'll come on to. So it's now becoming more and more apparent, certainly in the UK, that the number of patients in intensive care units is higher than the number of filtration machines that are available for routine use, which is why things like sustained low efficiency dialysis may become more frequently performed. And certainly I was talking just with Enrique Villar now, and he said he has been using this on patients in intensive care now, just because of the real pressure that there is on hemofiltration machines. And I think what the guidance coming out from NHS England is saying that essentially we should be, over a 48-hour period, we should be trying to allocate 1 machine to a minimum of 3 patients to try and reduce some of the pressure on the filtration machines that are currently going on in ITU. And the ways that we can do this is either by performing a high dose of filtration for around 8 hours, or performing dialysis. And the advantage that dialysis has is that it doesn't use the same filters that are being required for CVVH. And so that is an alternative treatment that is being advocated and is being used. The other thing that these intermittent treatments have an advantage over continuous treatments on is that it enables patients to be proned, and so that you can prone them when they're off filtration. Whereas if they're having a continuous therapy, that does make that more tricky. So the important things to do before you stop filtration on the machine is to make sure that their use and ease are safe, mainly from a potassium perspective, and also to check the phosphate, as the phosphate can become very, very low on these treatments, and you may need to replace phosphate. And once those parameters are safe, you can then wash the circuit back to the patient and decontaminate the patient to get it ready for the next use. And I think we are also experiencing the need to transfer filters to other units that may not have enough. And we're lucky at the Lister that we have an in-center dialysis unit, and we have the facility to provide dialysis treatments in ITU. So actually, by doing more dialysis and SLED in ITU, we can then free up some filters to give to other hospitals that may not have on-site renal services. One of the other things I just wanted to mention is about anticoagulation. There's been a lot of talk about how highly inflamed and prothrombotic these patients with coronavirus are. And there's been a real problem with filters clotting. And once the filter clots, then you've wasted the filter essentially. So I think there's some strategies coming out around anticoagulation. And I saw something this morning about how I think at Imperial they're using a slightly different dosing regimen for thromboprophylaxis. And actually for these patients in ITU, we may be having to systemically anticoagulate them rather than using more standard regional anticoagulation with citrate while they're on the filter. I should also just say at this moment that I think Joe and TJ mentioned it in their previous talk, but really assessing VTE prophylaxis and giving these patients deltaparin, unless there's a very strong indication not to, is an absolutely crucial tenet of management when we're seeing them through the front door, because the incidence of thrombosis is both on sort of microvascular and macrovascular is very, very high. So I think VT prophylaxis and VT assessment is absolutely key for these patients. Just going to touch briefly now on dialysis patients and what we should be doing and what we should be thinking about when we see dialysis patients. So in the UK alone, as of around about 12 days ago, there were 926 cases in the UK dialysis patients of coronavirus. And the 2-week mortality is 15.2%, which is much, much, much higher than the background population. So I think not only are these patients at higher risk of actually contracting coronavirus because they're not able to self-isolate, they have to come into hospital 3 times a week and are treated in very close proximity with other patients to receive a life-sustaining treatment. Also, when they get the virus, their risk of dying from it is much, much higher. And this led to Public Health England amending their PPE guidance for both the patients themselves and for healthcare professionals looking after dialysis patients. And essentially, the dialysis patients now fall into the extremely vulnerable category, which means that whether or not they have any symptoms suggestive of coronavirus, anytime we interact with these patients, we should be using disposable gloves, a plastic apron, and a fluid-resistant surgical mask. And actually, the patients themselves are being advised to wear fluid-resistant surgical masks when they're traveling to and from dialysis, and also when they're receiving dialysis treatment. So this is the sort of statement that the Renal Association came up with a couple of weeks ago, and they said that basically dialysis patients should be wearing masks when traveling to dialysis and in the waiting areas before dialysis treatment and assessment. as masks are provided for patients for travel and waiting rooms, these logically should also be worn within the unit for treatment if tolerated. And so I think at Lister, we've got about 15 or 16 COVID positive dialysis patients which are being dialysed in our new Florence dialysis unit, and about 4 or 5 who are possible positives at the moment. So I think we're trying to adhere to this guidelines, but it's just important to flag this up to you if you're seeing a dialysis patient overnight in A&E or in AMU, that we need to be using extra special precautions in this patient group because they're so highly vulnerable. Just some other things on dialysis that just sort of tie in with sort of the fluid management stuff that Alex has talked about earlier. There's sort of anecdotal reports, there's not much actual confirmed literature out there, that these patients may actually come in dehydrated and under their normal dry rate, which may all be related to the hyperpyrexia that we're seeing. And again, fluid resuscitation and careful clinical assessment of fluid status is so important in these patients. And there's just a few key questions that you can ask them that often patients, dialysis patients, will know the answer to this question. So they often will know what their dry weight is, and they will often know what weight they came off their last dialysis session at. And obviously if they're under their dry weight, then they actually may require some fluid resuscitation when you're seeing them in A&E. And how much fluid resuscitation relates to the difference between their current weight and their usual dry weight. And also it's important to know what their normal urine output is. As if they are anuric, they may be or they will be at a higher risk of developing fluid overload to some patients that continue to have a relatively normal urine output. And again, patients here at the Lister do a monthly urine collection. So most patients actually know what their urine output is. So that's another really useful question to ask them if you're seeing them in A&E out of hours. Again, like Alex has said, clinical assessment is really, really key. And again, focusing on inspection, so using your eyes and trying not to touch the patient too much, assessing for edema, assessing the JVP, assessing urine output, assessing the OBS, because you're really, again, trying to minimize your palpation auscultation, just given that this is another way of transmitting the virus. So again, just really focusing on a really good inspection in these patients. I think Alex is just going to talk a bit about CKD and immunosuppression now.
So Oscar's covered some of our at-risk patients, our dialysis patients, but of course there are some other renal patients who are also, I think, at more risk of COVID infection, serious complications. And this is a couple of meta-analyses that came out over the past week or so, essentially highlighting that if patients have CKD, they are at higher risk of a COVID admission. So essentially, if you've got a patient who has underlying health problems, then they are more likely to be admitted and won't do so well from coronavirus infection. So high rates there of hypertension, cardiovascular disease and diabetes. The CKD rate may look low, but I think that's more to do with the definitions that people were using for CKD. Suffice to say, in the meta-analysis, it came out as a significant factor in COVID admission. And if you look at patients with chronic kidney disease, again, this was a second meta-analysis looking at whether or not they develop severe COVID infection. And the odds ratio suggests that they do at 3, just over 3. We also wanted to mention some other important renal groups, so our transplant patients and our immunosuppressed patients. By way of an update really for you, transplant waiting list patients unfortunately remain on the waiting list. There are obvious concerns about ITU facilities. When we do a renal transplant, we use pretty heavy immunosuppression. With there being reduced ITU facilities and those beds being diverted to caring for COVID patients, and also obviously then the knock-on effect of having more infectious patients about, you can't therefore do as many renal transplants and immunosuppress people in that way. So because of that, all living donation has been suspended. And then the centres that do deceased donation for many of our Lister patients are in London and Addenbrooke's. And deceased donation has been suspended in London, and there's only really a very minimal programme going on at Addenbrooke's, which I think also faces possible suspension in the near future. So more about our renal patients, our transplant or immunosuppressed patients. It's not written on the slide, but it's worth mentioning that these patients fall into the shielding patient category. So just like Oscar was mentioning about PPE for these patients, you must be considering that as well for our transplant or immunosuppressed patients. In terms of them presenting with COVID infections, patients on immunosuppression may present atypically. So watch out for that. If you've got somebody who's non-specifically unwell, you must screen them for COVID if they're on immunosuppression or they've had a transplant. If you've got a patient that you're suspecting COVID infection or confirmed infection, then there are some things that we'd like you to do. So stop any of their anti-proliferative medications. So that's going to be their azathioprine or their mycophenolate. We are in two minds as to whether to advise blanket cessation of tacrolimus or cyclosporin. I think if you've got somebody with mild symptoms, then it would be reasonable to continue their tacrolimus. But if you've got somebody where you're very worried about them, that they've got severe signs of COVID infection, then stop the tacrolimus and tell the renal team what you've done. Get an early tacrolimus level. So if you can get one as a pre-dose level when you're seeing the patient, great. Otherwise, make sure that there's one out on that next set of blood tests and warn the patient that that's what you're doing, because the level needs to be pre-dose. If they haven't got a severe infection, then continue the tacrolimus until you've had a renal review and you've got a level back. Of course, most patients are also on steroid maintenance therapy, often at about 5 milligrams of prednisolone. We're recommending that you continue that, and in fact you increase it. So usual practice is to double that steroid dose. Obviously, if you're concerned that they're unwell and hyperadrenal, then you may well need to give them IV hydrocortisone as well. In any patient who has received rituximab as their immunosuppression treatment, and most patients will know that, so they have to attend a day unit for that kind of treatment, so they'll recognise the name and they'll know that they've had it. So make sure you ask them. It also is usually recorded on their renal letters. So any patients who have had rituximab, please check their serum immunoglobulin levels. Not necessarily a test that you have to prioritise getting off in the middle of the night, but make sure that that test is done. And then we'd like you, if you've got a transplant patient or a vasculitis patient, for example, who's had any of this immunosuppression, is on long-term steroid, tacrolimus, cyclosporin, mycophenolate, or azathioprine, then please inform the renal team of their admission. And it may be something simple and some phone advice, or they may need to go under renal care. So please let us know when those patients are in. So hopefully that's been helpful. We've talked about AKI and COVID disease, giving you some baseline data. We've talked about fluid management and the importance of monitoring your patients closely. Keep an eye clinically on their fluid status and monitor their kidney function. If you're worried, do that daily with a daily blood test. We've talked about ACE inhibition, and we've talked about the challenges facing us in terms of renal replacement therapy, and particularly the pull on our resources in this critical care setting. And we've discussed our high-risk patients, so our dialysis patients, and our patients on immunosuppression, and the sorts of things that you need to be doing for them when you're seeing them on the medical take. And hopefully that has all been of use. We've got a lot of people to thank who've given us advice in compiling this presentation. So we already mentioned Andy Findlay and Enrique Villa, Prof. Farrington. And then we've had advice from Suresh Madhavakanan, and then of course some advice from Barbara Thompson and Sarah Fluck, who are our vasculitis and transplant leads. If you want to ask us any questions, then please feel free. Our email addresses are there. We're happy to answer any queries or try and find out answers to things that we don't know. If you want to do a bit of research yourself, then we've also got some resources that you can follow. We were waiting, putting a slight delay on this presentation, awaiting the Renal Association guidance, which unfortunately isn't out yet, but we are hopeful that's going to be out in the next couple of days or so. So when that's out, if any of that evidence or guidance is contradictory to anything we've said, or there are any new gems or pearls that we need to pass on to you, then we'll make sure that we do that via the usual channels. And then there are some links to some other important and interesting content for renal patients pertaining to COVID. So I think that's everything that we were going to say for today. Before we sign off, Oscar, do you want to add anything else?
No, I think just more than happy if you get in touch with us with any questions that you've got, and we'll try and get the link out for the AKI guidance when it's published, which should be today, maybe tomorrow. But thanks for listening.
Bye.
Bye.